see if great, thank you. And thanks first of all to openEHR and the Foundation for inviting me back here this year. I'm delighted to be here amongst friends and colleagues. It's a great community and I take a lot of value from it back to London. I think there are some important contexts to what I do. I mean, you know, my job is about, it has the title of transformation through digital and data. So the question is, what difference can we make? And I think that's an important question just to frame some of what we try and do. And then the second thing I'd say is that London's a big old place. You know, it's a population of 11 or 12 million people. Depends how you count it, whether you get 11 or 12. There are different ways of counting these things, of course. And there are lots of different organisations. You know, the way healthcare is organised can make it easier or harder to implement good systems to make a difference. Because individual institutions have the ability to make their own choices. So how do you get them all to collaborate at scale on big projects? And I think they're really important. So the sort of the old phrase of people, process, and then what are the systems, I think is really important. Think about the people first. So, WHO, and this is a slide from a WHO report that was published last month, has looked at why staff working in health systems are not very happy and why they're leaving and it's not easy to recruit. And they've broadly said there are two sort of reasons. So the first on here is, you know, age of the workforce, the migration across various populations, part-time jobs, people have different expectations in their lives, and then the demand for services is going up. Populations generally have a higher proportion of older people, so chronic diseases are getting more prevalent and there's more demand, and there's a mismatch here. So when I think then of bringing this back to what's my job, it's, well, how can I do things that can make a difference to something in this axis? And I think that's an important question, and I come back to this slide at the end of my talk because I think there is a test for you to help me, because I don't have all the answers to everything all the time. And my teams don't, and I welcome any advice you might want to give or any different thinking you might want to give to us. So, this is a compilation slide of a number of programs that we run at the scale of London, okay? And it's really important that we get scale in there, because when we're evaluating the impact of technology, the unit cost can be dramatically reduced if we can get proper scaling. Now, the difficulty is that very often people will want to do their own thing locally, and we have lots of little things kicking off, all in a similar sort of space. So how do you alter that? And I think in London and certainly in England, we're being quite insistent that we're not going to use our investment capital to sponsor small things. We're going to sponsor bigger things at bigger scale. And that is a shift that is happening, and it's quite interesting to observe that and be part of that. So we have the shared record in London, across the whole of London. We have an ED handover system, which is the ambulances, data in ambulances automatically pre-populates in the arrival ED before you arrive there. We have a lot going on around mental health. We have a lot going on data. We have a lot going on around care planning. So I'm going to pick on 2 or 3 of these and talk about them a little bit, but then I'm going to say, well, what do we do now and how do we move that forward? So this is the shared record across London. It's taken us 5, 6, 7 years to get to the place where pretty much all of the organisations across London in health, the majority in social care, a good proportion of care homes. We have 1,200 care homes in London, probably 600 are now connected, and also things like hospices, you know, they're sort of for those people who are terminally ill, connected. It's viewed 2.5 million times per month across the London system. It saves an awful lot of time. And, you know, Queen's University Belfast independently evaluated it. This is available on our website. You can go and look. And in time, we're saving substantial amounts of money, about £5 million UK pounds a month, which over the life of this, and we launched it in 2020, April time, is substantial amounts of money now. And I know that whatever the economic position across London is, or across England, if I said to clinicians across London we were going to switch this off, I'd be lynched now. And, you know, I think that's a good place to be. It gives me a good argument to at least get some funds to move it forward. It doesn't make it any easier to get the money, but it gives me a good argument to get there. And I'm very grateful for this programme. The second programme, and this is a summary slide of some of the data in it, is the programme that provides the care planning function across London. It's an openEHR-based product through Better. And again, I'm very grateful to them. This is some data that we published last month. And we can see here that we produced in the month about 2,700 care plans. These are available across the whole of London. They can be multi-authored. They're linked into the shared record, so anybody with access to shared record can have access to these and vice versa. We make it very easy across the system to see these. The patients now, through the NHS app that exists in England for London, can see their own care plans. And that's been transformative. And I'm assured, and I'm looking at Thomas, December this year, patients will be able to start populating their own care plans. Okay? And that's a really important shift, which means we build equity into the record that the patient and the important things that patients have and the record that clinicians and the important thing that systems have. And until we can balance that equity, I don't think we're going to be able to shift ourselves forward as effectively as we want to do. Public expectations are changing, and we've got to reflect that change. This is really important because we're not doing this at national level. We're sort of doing it a little bit quietly. I'm announcing it here, but you're all a good lot. Because I think this will make a shift in what happens nationally because we're at such a scale in London. I can get lots of data very easily through this system. It's very easy to get data out of the system. I don't have to panic when I want some numbers. And we have lots of good reporting out of it. Very grateful for it. About 100,000 people now have care plans. We've extended it from those who are in their last months of life to those with sickle cell. People with sickle cell have a really difficult pain experience and pain management difficulty when they attend different institutions because usually junior staff get to see them and they have complex pain medication needs. We've extended to lots of people just with their general expectation of life, like frailty, chronic diseases. And we're currently actively looking at patients with crisis plans in mental health, maternity, and a few other areas. So we're trying to get to very big populations through this mechanism, and I think we will. This is where we're going forward for that care plan. It's a very good summary slide for a whole set of different areas. The one I like most is the ability for us to start to shape the equity equation across our populations. I think it's really important. Then let's move on to the third one, which is about data. So we have an approach in London which says we want to put the data that we have through all our systems in one place and link it so we can create one place where there's a longitudinal record. It can have multiple purposes, therefore, going forward, whether that's for active care, finding cohorts of patients with deteriorating disease profiles and intervening, whether it's for planning, how do we organise our health services, what do we do, or for research, whether that's research with industry on products, whether that's academic research. There are different ways of thinking about this. And we're doing this, as with the others, we're doing this once across London. And that gets us not just into foundational science, but into applied science and into improvement science. And the really important thing about improvement science is when we are going to adopt something at scale, I don't know about you and your systems, but the way we adopt and the way we look after people as we take them through that change is the hardest thing we do. And we need to bring more thinking to this space. There are good pockets, but doing this at a large scale across large economies is badly done. And the reason it's really important is because the rate of change is moving, it's getting faster. But the rate of change in tech is, but the rate of delivery of that change to a population is not really getting much faster. There's a very famous report in the American Medical Yearbook 2000, which talks about the time taken from agreement that a new medical technology should be put in place to it being adopted in the majority, and it's about 15 or 17 years, okay? We have set ourselves an ambition to do that in less than 12 months in London, and we should be doing it in less time, because we're not going to produce the efficiency, productivity, and improvement in population gains if we take this long to do stuff. So we think about biomedical, clinical, health systems, and operational research through these mechanisms, and that will give us a core linked record to support that. Now, in that record in London today, and this is an extract from Monday, so you can see the 12 million count here on the left of the number of people who are registered with our general practitioners across London. And if you go to the right-hand side, you can see there's about 8 million of their data running into that system now, and that's running in daily, initial bulk load and then daily change load. So we get that data daily, so it's got a 24-hour lag on it at most. And we put that with the hospital data, and we create this linked record. That's, significant. If I look at a few different areas across England and the world, the average integrated care system in England is about 2 million population. SAIL, which is the Welsh database, 4 million-ish. The Danish National Patient Record, 6.5 million. London at the moment, you've seen it, around 8 million. As we get to the second half of the year, we'll get the majority of those in, over 90%. We launched that in May this year. So we're doing this quickly in our normal terms compared to how we do it. So the way we put that together across London now is we think about the tech stack across London that underpins the work we're trying to achieve and the transformation we want to achieve. So you can see in these grey boxes we have the sectors in the service, whether that's GPs in primary care, there are about 1,200. Acute institutions, there are about 25 large acute institutions in London. Community, another dozen or so. Mental health, 8. 1 ambulance service, lots and lots of social care, 32 different social care services, 1,200 care homes, They've all got their own electronic records by and large. Okay, and they make their own choices. Now, we have influenced those to have a narrower selection, but much as we have heard, a lot of those are the monolithic EPRs that we know and love and hate at the same time, So the first layer here is the shared record. And that's a view only of that data. It doesn't really move the data. You see it, and once you go out of that view, you don't have the data stored in your system. That's provided by Oracle, okay, through their sort of standard IHE type mechanisms. The second layer is the universal care plan provided by Better. This does store data. It stores the care plan data and some other associated data. It's starting to have much closer links to the care record and to some other national services that access data as well, really important. And then the third layer is the data layer that I talked about. Now, the data layer we run in Microsoft Azure, and its primary analytical tool, although not its only analytical tool, is Snowflake. The important thing about Snowflake is the majority of academic institutions, NHS institutions, and council institutions in London all use Snowflake. So we have a single approach. We can start to really then change our BI resources and think about the analytics capability, which is a place we want to go to. That's linked into the NHS app through the Better work, the middle column. The ambition is to get it all linked into the NHS app. And, of course, in England, we have something called the Federated Data Platform, which is provided through Palantir, for those of you that know it, and that provides a number of sub-services across the country and into individual organisations as well. And we have to work in this framework. I don't have any other option but to work in this framework. But that we have carved out this bit in the middle that is London, and we can talk about that, gives us some independence to move these things forward and to challenge the national zeitgeist. We intend and are building this as modular scale as well and updatable. So it meets the open-air principles. It really does. And the more we can move in the direction of open air across the whole of this stack, the better. But there are some limitations to that. I think that's just a reality that we have to work in. And that is available whether you're patient, clinician, researcher. We want to make all that available with appropriate governance. And we've done a lot with the public in London. I'm not going to talk about that today, to involve them, to get their understanding so we can navigate that sort of governance and legal route. But of course, in England now, we have this proposition around a single patient record that's come along with a new government. In fact, more interestingly, is I think that originated in something called the Tony Blair Institute, which is sponsored by Oracle as well. So it's a sort of interesting sort of proposition, isn't it? And these are a couple of national slides that I've put into my deck because, the way this is presented is to link into the 3 shifts around hospital to community, sickness prevention, and analogue to digital. Although for me, I don't think analogue to digital should sit separately. It's interweaved in all of this. It's not, I think that's probably a slightly wrong presentation for me. It is, though, I think, making the very right proposition that patients first in terms of the data. It's shifting us in that direction. I think that is the right way to shift us. And there is a design plan and I'm not going to go into that in any detail. What's important is this slide, I think, which is the national slide that sets out 3 options that are being evaluated around that single patient record. Now, the first is based on what we do across the country with shared records, and can you create a standard approach and evolve from that, whatever the single patient record is. Bearing in mind, of course, that the single patient record isn't really defined very well. We've got to evolve it, I think, is the point. The second is based on a single national database. Probably the Federated Data Platform would be where that would be positioned, if it's possible. Although for NHS England to run a national database, it would need new legal powers for direct care. It can run databases for secondary uses. To get legal powers, I think, will take a bit of time through Parliament. It's not going to happen overnight. And then the third is leveraging some of the services that are available across England at the moment. And there's a product which is service-owned in the northeast, I think, called Interweave. And it's how that may help with other partners to go forward. So there is at least an evaluation process around this, and people are involved in that. What, though, we have to remember is the solution is not yet agreed, the scope and content is yet to be determined, and dates for a minimum viable product aren't really available. So in London, and on the right-hand side is London, is we want to develop an industry partnership with our main players. Okay, so how do we get a collaboration going with, Oracle, with Better, with IBM, because IBM provide the infrastructure for the NHS app, and how do we get our partners in a room? And we're starting that conversation. I don't think it'll necessarily be easy, but if we can make an alternative proposal into that work, I think we have the scale and the impact, perhaps, to do something in a different way and be more effective at what we deliver going forward because of our track record and our collaboration across London. But I have some problems. 2, I would say, big problems. One is this slide that Thomas showed earlier, this IDC report, and you can see that Better's in the leading and Oracle's in the major players. Now, if one of the principles we want to underpin what we do across OneLondon going forward is around open EHR and open data and those, principles, how do I get Oracle into that position? I can probably get IBM and the NHS app into that position more easily than I can get Oracle into that position. Those conversations are happening with Oracle, certainly around their middleware. I'm not sure they'd have them around their hospital EPR type conversations. And they talk about their data being very open, they comply with all the standards, but they need to be pushed, they need to sign up to the foundation. The other route, of course, is for us to persuade our national colleagues that we need openEHR as one of the underpinning principles for this going forward, and that creates a different sort of pressure into that space. And we're working on both of those. Whether we'll get there is a question I can't answer yet. So that's one problem. And any of you have thoughts around that, particularly with the large legacy providers, I call them, because they're not going away. I'll have them for another decade across London. And then the second is this: how do we organise ourselves? So the example we quote now is about the London Underground. And the London Underground in 1908, 1910, before the First World War, was a collection of different train systems that individuals own, and the ticketing from one to the other wouldn't work. The timetables weren't generally available. What happened then, sort of 50 years later, was Transport for London was formed, and that normalised the approach between them and meant there was an interoperable system. Now it's hailed as a sort of, world leading. But that was people coming together to agree that working collaboratively would be to all their benefits and changing the dynamics. And so we see what we're trying to do in London as an analogue of that approach. We're trying to bring all the providers together to try and make a collaborative going forward and have a sort of Transport for London for data and digital, really. And whilst this describes that in terms of the research, actually it will be extended to all of that infrastructure across London. Okay, important point. So we come back to this. We are making some changes to clinicians' lives, there's no doubt, and we are making some changes to the ease with which people have access to their data, can book appointments, and can get involved in their own care. Some of you will have seen only published this week, the majority of GP appointments now are made online. And 75% of the people in that sample, and it's tens of thousands in that sample who were asked, said it was easy. So we are shifting, but we haven't gone far enough, we're probably not going fast enough. So I finish there because I think I always want to focus on what's the change we're trying to make and what are the principal changes we have to deliver. I'll stop there. Thank you very much for your time. I'll take any questions.
Thanks very much, Luke. If you have any questions, just raise your hand. I'll bring the mic to you.
Must be coffee time.
Hi, I'm Dr. Rosa Colon-Colaco from Tufts University, and we're working a lot on health equity, and I was wondering how you are bringing the data for life sciences, clinical trials, and some of the opportunities sometimes that patients miss because we don't have the ecosystem connected
so
to
is it how are we involving life sciences across London?
No, how you bring in data. I love your dashboard,
yeah.
But I'm thinking about we have an opportunity as well to bring sometimes patients having clinical trials or wanted to be part of clinical trials, and sometimes that ecosystem get lost.
Yeah, so first of all, if you look at what's happened more locally across London, there are places across London where using data, the patients have been, the governance has been gone through, so patients are being asked, are you prepared to be involved in a trial? So when you've got that pre-permission, once you then have identified someone through your cohort mechanisms who may be suitable, you can then approach them. So I think that as we go through this year, once we get to March, that will be scalable across the whole of London. So if you think of trials as a particular bit. The second is, across London, we have a large number of universities that have separate funding routes through National Institutes for Health Research or other routes. What we've been doing is working with them and their national bodies to say, in any of the proposals that they put forward for research, they have to cite how they're using this data and these databases with our systems to support their work. And more fundamentally than that, we're saying, actually 5 universities might put forward 5 competing bids. On the infrastructure, you have to collaborate. You can compete on the use, but if you're using the infrastructure, you have to collaborate. And so we're getting close to the point where the 5 universities put together one bid with us about that work, and it's much more significant. So there are some really important changes happening, but this isn't about one bit of it changing. This is the whole stack of governance changing locally and nationally and in between. And there are some hard yards in that we haven't won yet. There are still problems to overcome.
Thank you. Just come to you quickly. Yeah, you can try and I'll get to you.
You mentioned it would help a lot if we were having discussions at the national level, convincing them about open air. Are you aware of that happening? If so, from who? Can you share any more about that? So pressure on the big providers to adopt.
Yeah, so there are some, I've had some discussions with national leaders about that, and it's not been ignored. So I think there are some other work going on for people to understand openEHR a bit more. And, you know, the need is for people at all sorts of levels, whether it's a technical level, a service level, a leadership level like mine, or an academic level, to be lobbying into our various places simultaneously, so that when leaders are testing propositions put to them, they're getting answers from lots of places which align. That's the only way we'll start to do this. And you know, there are some opportunities coming up, certainly in my world, in the next few weeks and months, that I will be using to put that forward as well. So let's see where we get to, would be my point. But if we don't try, we'll never know. I'm very fortunate that I can bring a little bit of weight behind me in the London system. And if I support the London system right, I know I'll get good support from some senior leaders across London to help me with that lobbying activity. So I'm not going to go into the detail, if you'll forgive me here. I think that would be a little bit disingenuous, but things are happening. But anything you can suggest, anything you want to do, get on with it. I like the JFDI motto.
Any further questions for Luke? Well, join me again in thanking him for his presentation.
Oh, thank you.